Dear colleague, welcome to this lecture on visual programming of DBS. We have previously looked at how DBS works and the basic principles, as well as on the anatomical foundations of programming. And we will now continue with visual programming. However, the question is, what is visual programming? The first thing we can conclude is that visual programming is not really visual programming. We do not really see what we are doing. It is in reality programming based on a visual model, and this model can be more or less exact. Visual programming is further not an all or nothing phenomenon, but it may be present to various degrees, as with the evolution of a site. And I believe that most of us have always used a visual model when programming. In its most primitive form, we have known where the electrode was intended to be placed, and we have formed an internal image in our mind of the electrode and the local anatomy as a foundation for our programming. At the next level, we have incorporated an image-based verification with CT and MRI demonstrating the location of the electrode and the individual contacts in relation to the local anatomy, hence reducing the level of uncertainty and improving the image in our mind of what we are stimulating. In the next step, we can move this model of the field of stimulation from our mind to the screen. Here we have an example of an intermediate visual model, not based on the patient's own anatomy, but where the user can place the electrode in accordance with what they consider most to resemble the actual location in their patient, and then to look at how various changes of the stimulation parameters will change the field of stimulation in relation to the anatomy of this brain atlas. The final step is of course a visual model with the exact location of the electrode and of the relevant anatomy based directly on the individual patient, as we see here. Thus, visual programming is nothing new, but the recent advances in technology has taken it to a completely new level. Now we do not have to satisfy with our mental image. With the new systems for visual guided programming, we can actually look at an image of the local anatomy in the form of an MRI investigation and the electrode based on postoperative investigation. The locations of the electrode contacts will further be displayed in this image, and probably with high fidelity. Further, we do not need to be satisfied with the anatomical structures that we can see in the MRI image. The program will attempt to identify these, regardless if they are visible or not to us in the original image, and to provide a model based on the individual patient's MRI. In this model, all the structures of interest are available to us. Further, we now also have advanced models of the field of stimulation and the volume of tissue activation, or VTA, giving us an impression of what we are stimulating and what is happening when we are changing the stimulation parameters in the individual patient. There are a number of potential advantages with visual programming. Firstly, we get a better understanding of how the VTA will change with the stimulation parameters. Previously, when we had simple quarter-polar electrodes with 4 non-directional contacts, then it was rather easy to imagine the field of stimulation as a simple sphere around the contact used for stimulation, and it was feasible to test every individual contact in a monopolar review and to base the programming on this, even blindly, without looking at images. Today, with directional leads, and especially with MICC, the fields of stimulation are much more complex, and it is not as intuitive. In order to understand how a change of the stimulation parameters will affect the size, shape, and direction of the field of stimulation, a visual representation is of great help. Further, with so many contacts, it will take much time and effort to test each one of them individually, and you will save valuable time by focusing on the actual area of interest. You might, for example, discard all options involving the internal capsule directly and choose a VTA in the actual target area before proceeding with more detailed evaluations. Another reason as to why visual programming is of value is because it helps many to understand the anatomy. As a neurosurgeon, I have always looked at the images and based on the location of the electrode in relation to the patient's own anatomy, formed an idea about which contacts will probably be best for stimulation and in which direction certain side effects can be expected to appear. But I have understood that this is not very common and that many programmers have not looked at the postoperative images but have done the programming in a completely blinded fashion. Further, I have come to realize that many non-neurosurgeons who are doing the programming have a limited experience in analyzing the local anatomy as seen on MRI, and often perceive this as more or less 50 shades of grey. At a recent meeting, a well-known neurologist said that with visual programming we can for the first time see the STN and where the electrode is placed. What she probably meant was that with visual programming it is easier to perceive the STN when the navigation system is analyzing the MRI images and is drawing a borderline around what it interprets as the STN and then fills this structure with a shiny color. Thirdly, visual programming provides a three-dimensional view of the area of interest, including the VTA. When we are looking at our MRI images, we are seeing two-dimensional representations of a three-dimensional reality, and to grasp the reality from these can be challenging. Now, we can get a three-dimensional image of the VTA in relation to the local anatomy. And finally, it helps us to understand how to optimize the VTA in relation to the local anatomy. In the navigation system, the anatomy is mapped and analyzed with artificial intelligence based on various algorithms, but a model is always a model and not a reality. Sometimes there will be a more or less perfect fit between the model and the gross anatomical reality. Often it is good, but sometimes there are considerable deviations. Ideally, an experienced person will correct the model according to the reality seen on MRI when planning the target during surgery or later. However, I suspect that often this will not be the case and that the programmer will simply accept the model from the navigation system as representing the reality. But this is perhaps not a major problem. Most often the model is good enough, and at least in the cases that I myself have seen with more significant deviations, this would still not have any major impact on how we plan the VTA. An example is when the electrode is placed somewhat medially of the STN according to the model, but when looking at the MRI it is clear that the electrode is actually in the STN, albeit at its medial border. In such a case, the VTA would be planned in the same manner regardless of whether the electrode is inside or just outside of it. With that said, I strongly advise that the model is controlled by someone who can interpret the MRI images. If you ignore this, then at least this should be done if the patient is not responding to the stimulation as expected. Unfortunately, even if the model is in accordance with the gross anatomy, this does not provide us with an answer of exactly where to stimulate. We are still arguing about where exactly to place the electrodes within the different brain targets, and there is even less agreement on where to stimulate. We can look at a map, a model, and the real images. However, even the real images will not show us everything. Here is a map of my house, and we will of course see much more with a satellite image, but still we can't see inside the house. Many details are not visible, and we have no idea what is going on there. DBS is an art and not always an exact science. Hence, even if you have stimulated exactly what you believe to be the target based on the visual model and real images, you might still have a poor effect or unexpected side effects. Programming is based on clinical experience, and there are currently no maps that will tell us exactly where and how to stimulate. It is not possible to base programming just on the model or MRI images, but visual models can point in a general direction and narrow down the options. Visual programming is great when you want to know where you are and where to go, but in order to get there, you need to align the map with the real world, and that is the actual stimulation response. Remember that it is not visual programming or stimulation response guided programming, but a combination. We use a map to find the general direction, and we will then decide on the exact field of stimulation based on the stimulation response encountered. This is a feedback system where we will look at a map and then try some stimulation settings and the field of stimulation based on the map. We will then look at the stimulation response regarding effects and side effects, and in light of these, reinterpret the map and refine the stimulation parameters before we will make the final adjustments, mainly based on the stimulation response. So we then come to the more practical aspects of how to do visual programming. The first step is that you need to learn how to master the software. If someone has prepared everything for you, then this is not very complicated. But if you need to set up everything yourself from the beginning, then it is a somewhat complex procedure requiring some training. You will find some information in the lecture seen here, but I recommend you to take the course in the provided link seen here. I will not repeat this information in the current lecture, but we will now move on to the next step. And that is that you need to know what to stimulate. What to stimulate and what not to stimulate when using visual programming is of course based on the visualized anatomy of the patient, and this is discussed in detail for the common targets in this lecture. So I suggest that you make sure that you have looked at this in detail and that you have a good understanding of the anatomical foundations of programming DBS before you continue. If you don't understand the anatomical foundation, then visualizing it will not be very helpful. If you are just starting with visual programming, then I suggest that you upload a few of your successful cases stimulated with what you consider to be typical stimulation parameters, just to get a feeling of how the field of stimulation can look regarding anatomical location and size in such patients. Another good idea is that you then do the same with some patients with poor outcome to see if you notice any differences and can formulate a hypothesis why this might be the case. And this is of course not possible only for patients implanted with the new directional electrodes. You can as well analyze your previously implanted patients with omnidirectional leads. So we start the session by making a map or a model with the electrode and the anatomical structures that you find to be of interest, such as your target, the internal capsule, and so on, in order to orientate yourself and to decide on the location of the electrode in relation to the intended target and the approximate area where you would like to place your field of stimulation. If you have a good understanding of the anatomy, then you will probably skip the first step and move directly to the second step, where we remove all the non-essential anatomical structures. The more structures you are looking at, the easier it is for you to get confused. So I suggest that when programming STN-DBS, to only look at the STN and red nucleus. When programming the VIM or PSA, use the same structures and the VIM itself. When programming the GPI, display only the GPI and perhaps the GP. The reason why we add the red nucleus or the GP is mostly in order to provide an immediate understanding of the laterality. If you get confused and start to question your memory, then you can always temporarily add another structure, such as the internal capsule. One of the advantages with visual programming is that you can see everything in 3 dimensions and from every possible angle. But this can at the same time also easily create disorientation if you are not very familiar with anatomy. Thus, I encourage you to move around to get a good overview, but also to create a mental default view to which you can always return if you start to feel disoriented. By using this view, it will also be easier for you to build a library in your mind of all your patients and to draw from your previous experience. I suggest that you, as your default view, look at the patient from behind in an erect position. We then look at the electrode and location of the individual contacts within the target structure in detail. You can now decide more in detail how you want to shape the field of stimulation, first in your mind and then in the model by changing the stimulation parameters and moving the field of stimulation. As I mentioned earlier, we do not know exactly where to stimulate within the target area, and the same stimulation fields will not have the same effects in all patients, but a visual analysis will point us in the general direction, and we can avoid spending time on exploring stimulation fields with little chance of success. Here we have a rather well-placed electrode, and we mostly need to decide on which level to focus. When the electrode is slightly off the intended target, as in this case, then it seems natural that we would like to move the field of stimulation towards the intended target, as seen here. And as you can see, it is necessary to look at the field of stimulation from different angles to get a good understanding of its location and how it is related to the surrounding structures. If you find that the electrode is completely outside of the intended target, then it is probably better to contact the surgeon instead on wasting your time on programming. Here we see a patient with intended STN-DBS where the electrode is far behind and medial to the STN, and there is no chance for you to reach the intended target with your field of stimulation. I will now and then receive patients for second opinion where the referring center has spent years on trying to optimize the stimulation with little success, and where a quick glance at the location of the electrode is sufficient to decide that the electrode is so far away from the intended target that there is really no chance of a successful outcome. So, by looking at the location of the electrode, you might save yourself from many hours of futile and frustrating attempts. In the STN, I believe that it will have the best effect and least side effects if we focus the field of stimulation within the red area seen here in the two-dimensional images, and do not let the field of stimulation stretch too much outside the borders of the STN. With that said, we should not be afraid to try stimulation fields transgressing these borders in the horizontal plane. And as I mentioned, what you see is a model, and we have not decided on where the optimal area for stimulation is in the STN. Be also aware that many patients with so-called STN-DBS are actually stimulated using contacts above or at the border of the STN, so don't be afraid of using fields of stimulation which extends above the STN. We can't see the VIM. This is also true for the navigation system. It will just create a model based on landmarks. Hence, the uncertainties are larger here, but we can put some trust in the atlas and what it suggests to be the VIM. Further, we will also see the internal capsule and thus know what to avoid. We can also look below the VIM itself at the PSA, where many patients with so-called VIM-DBS will have contacts and where these patients often achieve the best effect of stimulation. And this area is well delineated by the STN and the red nucleus. And finally, we have the GPI, which is well visualized on MRI and where we want to have a field of stimulation covering a significant part of the posterior third of the structure, preferably without involving too much of the internal capsule or other structures outside of the GPI. But just to repeat, it is not wrong to stimulate outside the target structure. This is not a coloring book where you need to stay within the lines. The goal is not to place a maximal volume of stimulation within the lines delineated the target structure without crossing these in the visual program. The visual program is there to guide you, but the finer details are based on the stimulation response. So, before ending this presentation, I would just like to mention one consequence of visual programming, which we neurosurgeons will have to be aware of. Before visual programming, most programmers would simply have to trust the neurosurgeon's word regarding the location of the electrode. But with visual programming, they can look for themselves. This means that we neurosurgeons now find us in a situation where our work will be scrutinized by others. This was just an introduction to visual programming, and I hope to return with some more detailed lectures on visual programming of the individual targets later. Thank you for your attention.